Cutaneous larva migrans is a skin disease in humans, caused by the larvae of various nematode parasites of the hookworm family, Ancylostomatidae. The most common species causing this disease in the Americas is Ancylostoma brasiliensis. These parasites live in the intestines of dogs, cats, and wild animals and should not be confused with other members of the hookworm family for which humans are definitive hosts, namely Ancylostoma duodenale and Necator americanus. It is colloquially called creeping eruption due to its presentation, and also as ground ditch or sandworms, as the larvae like to live in sandy soil. Creeping eruption usually appears 1 to 5 days after skin penetration, but the incubation period may be equals 1 month. Typically, a serpiginous, erythematous tract appears in the skin and is associated with intense itchiness and mild swelling. Usual locations are the foot and buttocks, although any skin surface coming in contact with contaminated soil can be affected. Cutaneous larva migrans is self-limiting. Migrating larvae usually die after 5 to 6 weeks. It is therefore typically self-limiting and eventually resolves completely without sequelae even if no specific treatment is used, usually within 2 to 8 weeks. However, giving an anthelmintic medication results in rapid resolution of symptoms, usually within 1 week. Pruritus and extension of the creeping eruption often resolve within 48 hours of therapy. The rash disappears more slowly. Even though cutaneous larva migrans is self-limited, the intense pruritus and risk for infection mandate treatment. Prevention is key and involves avoidance of direct skin contact with fecally contaminated soil. Oral albendazole, oral ivermectin, or topical ivermectin are the usual treatment choices, recommended. If there is no response to initial treatment after 1 to 2 weeks, no reduction in pruritus or the creeping eruption, treatment can be repeated using the same drug and dose. In a small minority of cases, a third course of treatment may be required, for example, if folliculitis present. However, if symptoms and signs have not resolved after 2 courses of treatment, referral to a tropical medicine specialist and/or investigation of alternative diagnoses should be considered. Symptoms and skin findings may recur after an initial positive response to treatment, probably because the hookworm larvae were damaged but not completely killed. Relapse usually occurs within weeks of the initial presentation and responds in most cases to a repeated course of treatment.